Okay, I guess everyone's here, so we'll get started. So today we're going to do neuromuscular disorders. This is the last lecture for your exam on Friday, so tomorrow will just be reviews, some case studies and whatnot. So this is the last one. So we're going to go through some disorders. As I mentioned last week, when you're doing neuro, you got to figure out is this a brain problem, spinal cord, peripheral nerve, muscle. That's what we'll be doing today. So we'll start some spinal cord disorders that we're going to go through, some nerve disorders, some isolated neuropathies, multifocal neuropathies, multiple sclerosis, polio, Guillain-Barré, and so on and so forth. And then finally, our neuromuscular disorders and our muscle disorders. So remember, we have to go along the line and see what part is where you're having your deficiencies. So again, always gather information. Is it a weakness or is it a neuropathy? What's the difference? Weakness. What's the problem with weakness? It's a motor problem, right? If you have a weakness, it's a motor problem. If it's a neuropathy, it's a sensory problem. Okay, they can have both. They can have one or the other. Okay, so you can, again, it's a lesion that involves a nervous system. It could happen in central or peripherally. Other words, a definition that you'll be using, numbness is a feeling of heaviness or deadness. So get to certain things later on with neuropathies and arms go numb, or you call it falling asleep. Paresthesias, abnormal sensation of burning, tingling, pins and needles. Those are paresthesias. Neuropathy is a disturbance in the function of the nerve. And then radiculopathy, again, is referred pain along the dermatome. So when you talk about like sciatica, okay, sciatic pain is due to the sciatic nerve, and the pain will travel down that nerve root, down that dermatome, and that's where they complain of all the pain. Other sensory deficits, a plexopathy. This has to do with the nerve plexus. So your brachial plexus has a lot of nerves in that one little area. If you're messing up with a bunch of them, it's called a plexopathy. A myopathy is just a primary muscle disorder. Neuropathies, most of them are classified as sensory motor, so they involve some sensory deficit and some motor deficit. They're going to have usually all of those with some reflex changes are there as well. Some, again, predominantly motor or sensory. The predominantly motor ones, Guillain-Barré syndrome, hepatitis, and lead poisoning. Those will give you primary motor deficits. Sensory issues, leprosy. That is a pure sensory. Some industrial solvents and some hereditary things. So those are pure sensory issues. Peripheral neuropathy, you're going to hear about that a lot when it comes to like diabetes. That's one of the big ones. Usually going to affect, obviously, your peripheral nerves, so anything peripheral to the spinal cord. So cranial nerves are included because they are not central, they're peripheral. All those peripheral autonomic nervous system roots. Now, when a nerve gets damaged, there's only a certain ways they can respond to injury. Either you get damage at the axon itself, so you cut that axon, no more transmission of the action potential down, therefore no release of neurotransmitters, no connection to the next cells. Disruption of the axon, and that's getting rid of your myelin sheath. So the myelin itself is not encasing your nerves, therefore you lose your conduction as you go through the length of that axon. Or degeneration of the axon, breakdown of that myelin sheath. This is usually due to metabolic or toxic problems. So when we start learning about different diseases, you'll see some are demyelinating. We're going to learn about ALS today, amyotrophic lateral sclerosis. That is a retraction of the nerve. It comes off of the muscle, it atrophies, and that nerve gets smaller. And remember, if that nerve doesn't touch the muscle is not going to work. Muscle weakness can be a disease of the muscles itself or the nerves that stimulate them. So we do neuro and ortho together. So if someone comes in with leg weakness, think about all the systems that are in your leg. What do you have in someone coming with leg pain? What are the systems in your leg you have to worry about? Nervous system. What else? Vascular. What else? Musculoskeletal. Even the skin, because the skin covers the entire area. If you have compartment syndrome, you have swelling, and then obviously you can't go anywhere. But with that compartment syndrome we learned about last year, they get compression of your soft tissues, causing nerve pain going down and so forth. So, more definitions. Paralysis is the complete absence of strength. Paralyzed. Also called plegia. So when you see the word plegia at the end, that means total paralysis. So a hemiplegic person, both limbs, one side of the body. Okay, so one side, upper arm, lower leg. The whole side is down. Paraplegia is both legs, and a quadriplegic is all four limbs now don't work. So in order to be quadriplegic, where do you think the injury has to be? In the neck or above. Because anything lower, your arms come off earlier, C1, like, maybe C6, C7, all that stuff. If it's a T1 spinal transection, everything downstream of that is gone. So usually the hemiplegias, what would cause a hemiplegia? One side of the body is out. Stroke. This is where strokes come in. Because strokes affect the opposite side. If you have a left-sided stroke, the right side of the body is going to be affected. Paresis is just less severe weakness. So someone's coming in like a transient ischemic attack, and they have weakness on one side of their body, but they can still do things, then you consider that paresis, hemiparesis. And that is what you would write in your notes, because they still have some strength, but they don't have full strength. Myopathic disorders, again, things that deal with muscles only, usually starts more proximal and then works its way up. So we'll talk about ALS later on today. Usually one of the first things patients with ALS have a problem with is like holding a cup of coffee. It starts distal and works its way. Or more proximal than distal, but the ALS is different. No muscle wasting or depression of DTRs until advanced stages. They're going to have normal abdominal and plantar reflexes. Why are they going to have normal abdominal and plantar reflexes? What's special about those two? They go to the brain. So they go all the way up. No sensory loss or sphincter disturbances. You'll see that with poliomyositis, dermatomyositis, and muscular dystrophy. Still going on with our assessment. Is the weakness that patient is describing, is it due to a muscle disorder itself? Is it a motor neuron disorder? This is where you start worrying about, is this an upper motor neuron lesion or a lower motor neuron lesion? So we went through that on the first lecture, the description in that one table. I said, make sure you know this table. It has like bulk and use and all that stuff. If it says upper motor neuron, those are the problems you're going to have if you have an upper motor neuron disease. If you have a lower motor neuron lesion or a problem, that column is what you'll have with a lower motor neuron. If it's a sensory deficit, your neuropathies, is it focal? Is it just my right foot? Is it multifocal? Is it symmetric? Are both sides affected or just one? Proximal, distal, where are you having your problems? Be very descriptive as far as what the patients complain of. I complain of leg pain. Well, the leg is very big. What part of the leg are they actually having problems with? So ask all these questions when you talk to your patients. Some historical factors that are very important. The onset of symptoms. If it happens abruptly, vascular. Strokes are very sudden. Okay. Subacutely over days to weeks, neoplastic, infectious, could be the problems there. If it's slowly progressing over months to years, it's your degenerative, it could be metabolic, it's your endocrine problems, the neoplastic cancers, they take a long time to develop, so it's not going to be happening within days, weeks, it's going to take a lot longer than that, months to years. Is there a progressive increase in motor deficit? That means continuing activity of that underlying process. A lot of the times in medicine, you got to figure out why are they having these complaints. Okay, I think I mentioned this before, but good clinicians will figure out why are they having these problems. Bad ones will just treat symptoms. You keep throwing Band-Aids at things to treat symptoms. If you don't get at what the underlying problem is, you won't treat your patients. If the progression is episodic, you have flare-ups and remissions, vascular or inflammatory origin. If it's steadily progressive, just getting worse and worse and worse and worse and worse as time goes on, could be a neoplastic problem or some motor degenerative conditions. If they have rapid fluctuation of symptoms over a short period of time, that will be myasthenia gravis, and we'll go through that today. Your physical exam, your muscle, you're all viewing the muscles. Is there atrophy in the muscles? Is it on one side of the body versus the other? Any fasciculations? Do you see any muscles twitching? Watch out for those. Muscle tone, okay, spasticity, okay, how fast are these muscles moving? Is it rigid, like that lead pipe rigidity, because they have dopamine issues, they can't go nice and smooth. Your strength testing, usually your hand grip strength, or you just give your fingers and have the patient squeeze your fingers and see how much they can squeeze. Check your reflexes. Are they hyporeflexic, hyper? Is it asymmetric on both sides? Sensory testing, and obviously your gait analysis as well. Look at obviously foot drop is a big one. Circumduction is when they're walking normally, instead of everything straight, their legs bow out like circles because of the way they have to walk. That's circumduction. So again, analyze how they're walking. So again, is it a brain problem, spinal cord problem? Is it a nerve problem getting to the muscle? Is it a neuromuscular junction problem? Or is it a problem with the muscles that's causing these patients to be weak? Okay, so we're going to go on to spinal cord disorders. And I figured out a way to get around this. Okay, so you all anyone watch that Logan Paul or where was the one? Fought Mike Tyson. This is what Mike Tyson was back in when he was really crazy.
I broke my back.
What do you mean by that?
My back is broken.
What, a vertebrae or what portion?
Spinal.
What does that mean? Who knows? Okay, that's Mike Tyson. Okay, let's move on to spinal cord problems. Red flag symptoms. Look at any history of trauma. Okay, a car accident. Okay, hit with something. If you suspect any trauma, rule out fractures and get your plain film x-rays to see if there's any fractures in the vertebrae and so forth. Is the pain worse at night is a big one. Rule out malignancy. Okay, and get a CT or MRI urgently. A lot of the treatments in neuro is going to be go see neurosurgery or go see neuro. Just like in endo, a lot of the endo treatment is go see endo. You'll have to give the real answer first, but on both of them. But yes, is the first thing usually go to endo? Yes, but you guys have to know all the material. Bowel or bladder incontinence is a big one. You have to rule out cauda equina syndrome, and we're going to discuss that today as well. So the first one is a total spinal cord transection. Spinal cord's cut, everything downstream is lost. Most common motor vehicle accidents, as far as when they show up to the ER with these things, 20 or so years ago, Dale Earnhardt, race car driver for NASCAR here in Daytona. This is before all the regulations for the head and neck devices. Immediately when he hit the wall, his neck was transected. It was immediate. There was no waiting. There was nothing. He was dead in the car when they got there. Because of, now they have head and neck supports where they can, like, their head doesn't move, but from the abruptly stopping, his head went forward and spinal cord was done. Immediate flaccid paralysis and loss of sensation below the level of the injury. So when you're studying this section, we're going to do this a lot more in detail when we get to Brown-Séquard, which is the next one. At the level of the injury, above the injury, and below the injury, what kind of deficits are they having? Also have to watch out for spinal shock. You get loss of reflex activity. They get hypotension due to unopposed vagal tone. So they basically, vessels just open wide. Pressure drops due to spinal shock. And we'll go through this in a second. They have flaccid reflexia, lasts hours to weeks. It's like the spinal cord is like stunned from the injury and the swelling. Reflexes will eventually recur as hyperreflexia if they do come back. So here's an example, the fracture of the vertebrae, and it transected that and injured that spinal cord. So that's an example of how broken vertebral spines can cause issues. So imaging, CT scan will show bone damage. MRI can be performed if able. Again, can they lie down and so forth, to show the extent of the damage. They go right to the ICU. They have to go there because of all this problem going on with their vital signs. You have to watch everything else now. Breathing, check neural signs every 2 hours to see how they're doing. Obviously, they need to be on monitors, and blood pressure needs to be monitored. So complications of a total spinal cord transection. Cardiovascular, they get this neurogenic shock. It's a distributive shock. So remember, when we did cardiopathophysiology, there were 4 types of shocks. Distributive was one of them. Low blood pressure, slow heart rate, and this is disruption of your autonomic pathways, causing decreased vascular resistance. So those vessels are just wide open, pressure drops. Respiratory considerations. They can have respiratory failure, go to pulmonary edema, pneumonia, aspiration pneumonia, pulmonary embolism is there. So watch for signs of impending respiratory failure. And then depending on where that spinal cord transection occurred, you have to start thinking about long term. If they can't support their breathing and they are on intubation, you can't keep a patient on intubation forever. So you take them off and you worry about getting a trach, especially if you know that their breathing support is not going to return. You get a trach and the trach will breathe for them. DVT and PEs. Patients are now going to be bedridden. They're not going to be moving. So now we have venous stasis. You have to worry about blood clots because they may throw a clot later on. Now you got a PE to worry about. Okay, so all should get prophylactic treatment, heparin, Lovenox in the hospital to prevent the clots. Other medical complications, pain control you have to worry about. Just be careful with opiates. Pressure sores, again, they're not going to be moving. They're going to be in bed all the time. Okay, pressure sores commonly happen on the buttocks and the heels. You can use air beds, rotate them around so they don't have those pressure sores. When that bone hits the skin, it blanches out the blood. And if you leave it there for too long, you start getting ulcer formations on those pressure sore sites. Urinary catheterization. Okay, if they can't control their bladder, you may have to do some urinary catheterization. You want to avoid, obviously, UTIs. GI stress ulcers give PPIs. There can be a lot of stress and a lot of inflammation in the body. You want to watch out for ulcers. Paralytic ileus. Okay, bowel motility may be silent for days to weeks. If this happens, you cannot give any food until you start hearing bowel sounds. Or ask your patient if they're passing any gas. If they're passing gas, that means their GI system is moving now and they're able to push air out. Then they can start eating food because now the food will move. If the GI system is stunned, not doing anything, giving them food, the food's not going to go anywhere. Nothing is moving it through the system. Temperature control. You have to watch out for these patients' temperature. They can't auto-regulate themselves. They also sometimes they can't sweat below the lesion because the nerves, remember, the nerves go to the sweat glands as well. And if the nerves aren't working, they're not going to tell the sweat glands to constrict to get sweat out. So watch out for the environmental temperature of your patients. Everyone who's had any type of like spinal cord issue, PT, OT, physical therapy, occupational therapy, get them involved early. They're going to do a lot of the care for these patients afterwards because they're going to need constant physical therapy later on. And the last thing is nutritional. If these patients can't swallow, they can't get their food that way, you have to figure out another way to get these patients foods. So parenteral, if that's still not going to recover, then you can start worrying about a J tube or a G tube, and they can get fed through a gastric tube. So treatments, methylprednisolone. What is that? The steroid. Why do we give steroids? Anti-inflammatory. That's why you have non-steroidal anti-inflammatory drugs, because steroids are anti-inflammatory. So usually we'll blast them at first with steroids to kind of reduce the inflammation of the spinal cord. Don't use if they have any type of penetrating injury, multi-system trauma, or any type of severe traumatic brain injury. Don't give them methylprednisolone. Any type of spinal cord transection, immediate immobilization and surgical fixation, which is why when you see like on the football, they leave the helmet on, they take the mask off, but they keep them fixed in that bed, because if they try to move their head to get the helmet off, you can move around and you make that spinal cord worse. So you got an immediate fixation, immobilization, and go from there. If they start getting any painful spasms, you can give baclofen or some benzodiazepines like diazepam. Just a lot of things we do in neuro is symptom management. So whenever you see spasms, think baclofen. That's usually the first line therapy for spasms. We give baclofen. Prognosis of patients, 4 to 20% will have an early death. So the age of the patient, the level of the spinal cord, where do they have their injury, neurological grade predicts survival. The higher that spinal cord transection, the worse the prognosis is. Okay. Brown-Séquard syndrome results from a partial cord transection, so also known as a hemisection. Okay, usually from penetrating trauma, so you get stabbed and whatnot. So let's draw it out and we'll review some of these tracks as well. So, your lateral corticospinal tract, what does that carry? Motor or sensory? Motor. Why is it motor? Corticospinal. It starts in the cortex and it goes down to the spine. Where is the crossover? Where does this crossover occur for motor neurons? Pyramids, and where are they? Lower medulla. Okay. Fasciculus gracilis and cuneatus. What is this also known as, this entire part of the spinal cord? Dorsal white column. Again, sensory information. Discriminative touch, vibration, and proprioception. Where does this cross over? This sensation. Spinal cord or in the medulla? This is in the medulla as well. Lateral spinothalamic tract. Sensory or motor? Sensory, again, spinal thalamic, from the spine to the thalamus. Pain and temperature goes in this tract. Where does this cross over? At the level of the spinal cord, higher up the spinal cord, or in the medulla? At the level. And the last one, anterior spinothalamic tract, light touch and pressure. Where does this one cross over? At the level again. Okay. Any questions so far? So, in Brown-Séquard, what happens is we lose half of the function. It's gone. Half of the spinal cord at a certain level. Guess what level we're going to pick? T10. It's easy to remember, it's the umbilicus. We're going to see what happens at the level of the spinal cord at T10, below the level, and above the level for each one as we go through these. So, first one. Okay, so we're going to look at this three ways. T10 is the issue. So we're going to look at it at the level. We're going to look at it above. And we're going to look at it below. Where are they having deficits and where is it occurring? Okay, so we have right side, left side. And we're going to talk about this one is below the injury. So we're first going to discuss this below the level of the injury at T10. Pain and temperature. On the right side of the body, will this patient be able to sense pain and temperature on the right side of the body below the injury? No, they will not. Because pain and temperature comes in, remember it crosses over, and then it goes up. But as it goes up, it can't get above it because T10 is damaged. It can't go up. It stops right there. So we lose that sensation. What about below the injury on the left leg? Yes, you can get those just fine. Pressure and light touch. Will you be able to sense anything on the right leg below the level of the injury with light touch and pressure? It follows the same thing as pain and temperature. Will the left leg be able to sense light touch and pressure? Yep, we're good there. Now, vibration, proprioception, and discriminative touch. On the right leg, let me change the color for this one. Remember, for this one, we got the little ganglion there. It comes in and it goes up the same side. On the right leg, will the right leg have any problems with vibration, proprioception, or discriminative touch? It's going to be good. Left leg, below the injury. Can that signal get through T10 on the left? Nope. So you lose function on the left side. Okay. The last one is with below the level of the lesion with upper motor neuron or lower motor neuron diseases. On the right side, the right leg, I'll put this in blue. Where is the crossover for motor? Where? Go higher. Medulla. Motors in the medulla. So blue, going to come in, work its way up, then it crosses over later. So are you going to have any problems with motor function on the right leg below the injury? It's going to be fine. What about the left side? So remember, these are coming down because these are motor. This is what motor neuron is, the top part that I'm drawing here in blue above the spinal cord. This is your upper motor neuron. The lower motor neuron doesn't happen until it synapses. And where does motor synapse? Anterior gray horn. As this upper motor neuron comes down, It's going to get blocked at T10 because that's where the injury is. Will you have any upper motor neuron impulse to your left leg below the injury? Is there any issue with the lower motor neurons? No, the problem is upper can't get to it. And so remember, I always talk about outlets in the wall. Okay, the outlet itself is the synapse. The power from the breaker box that goes all the way to the outlet is the upper motor neuron. If I cut that, will that outlet ever work? Nope. You can plug into your iPad chargers all you want, and they'll work fine, not in that outlet because the upper motor neuron got cut. So below the level of the injury on the left leg, they're going to have upper motor neuron lesions. So that table I told you to remember those symptoms from an upper motor neuron lesion, that's what they're going to exhibit in their left leg when you hemisection of T10 on the left. Everyone good as far as what happens below the injury. So if you look, these two are contralateral issues. The injury is on the left, but they have problems on the right. And it has to do where they cross over again. Look at vibration, proprioception, discriminative touch, and your motors. They cross over in the medulla, which is going to be higher than most everything in the spinal cord. So they get ipsilateral problems. Same side lesions. So this is the injury on left T10. Left lower extremity loses vibratory touch, discriminative touch, and they exhibit signs of upper motor neuron disease. Everyone good? Okay. Move on to the next one. Now we're going to talk about at the level. At the level of the injury itself. So we're talking about just T10 itself, and wherever that dermatome goes with those sensory and motors, we're talking about just T10. Pain and temperature on the right, any problems there? Remember, it crosses over, it can get up, we're okay. Right is going to be okay. What about the left side? Nope, it's going to be down here. Pressure and light touch is good, but you lose it at the level because there's no more synapses going on at T10. Everything's been cut at T10, so nothing can happen downstream of that. Vibration, proprioception. Any problems on the right side? Right side goes all the way up, no problems there. On the left, they're going to lose it. Remember, these don't cross over until the medulla, so they go straight up the same column, the same side. The last one, upper motor neuron, lower motor neuron. So we cut the spinal cord at T10. We obliterated everything that happened there. Will that lower motor neuron work at this point? We destroyed the whole thing, so even the cord coming off. Nope. So at the level of the injury, on the right, they're okay. They get lower motor neuron type symptoms at the level of the injury. So if it's T10, T2, L5, you know, okay, that's the level we're at. No matter where you are, that's what they're going to lose. It's always the same. Know what side it's on and go from there. On your exam, make sure you read all the words, because I may put in right or left side. Also, I may throw in spinal thalamic versus cortical spinal in there. Make sure you pick the right ones. Okay? So this is at the level of the injury. What about above? Any problems, do you think? Will there be any sensory issues or motor problems from T9 up? Nope, everything is good above the injury. Good, and we're good. So let's put it all together, and we have our guy here with our dermatomes. We know that our issue is at T10, which is right here. Okay, that's where our injury is. Where did it go away? Okay. Okay. So, what sensations are we going to lose the right lower leg in red? What are we going to lose when the injury's at T10 on the left? What sensations are we going to lose on the right lower extremity from T10 down? Pain and temperature. What else goes in the same direction as pain and temperature? Light touch and pressure. That's what we lose on the right lower extremity. What about in blue? Okay, we have our left lower extremity below the level of the injury. What's going to happen with that leg? What are we going to lose? Yep, we lose vibration, proprioception, and 2-point touch. What kind of motor issue are we going to have? Upper. I'll put upper motor neuron lesion below the injury. Okay. What about at the level? This will exhibit a lower motor neuron lesion. And what about sensory? They lose all sensation, everything. All sensation is lost. Remember, at the level of that dermatome, so T10, wherever it goes, that's where they're going to have deficits. So it's like finding a game and figuring out where the deficit is. And when you guys do your light touch and pressure and sharp and dull and all that stuff, I talked with Professor Kim, and for your neuro lab, we're going to give you guys a game. You got to figure out where the lesion is. And you'll get a card that says C5, and make sure you as a patient remember, okay, they're doing C5. I'll say, I don't feel anything. I don't feel anything. And you go from there. Okay. So again, summary slide puts it all together. These are your upper motor neuron lesions. And these are your lower motor neuron lesions. Just again, to refresh your memory, what are the problems that they're going to be having? Yes?
Why is it that at the level they still have sensation on the right side? Wouldn't it cross over to the left?
So on the left side, for some reason, the left side still works, even though some of them cross over. Because their nerves it's all one nerve. I don't know exactly how it works, to be honest. I would just know it for face value what happens.
Okay, so for pain and temperature on the right, it's still good at that level?
Yes. Just on the side that was damaged. So this is left T10. Only left T10 will have issues. The right T10 will be okay. And you're going to go through this again with Professor Russell when she comes in for ortho. You guys will do Brown-Séquard again. You got to get more used to it. So let's talk about Brown-Séquard. Caused by trauma, tumors, infections, usually someone falling off a ladder. Again, diminished motor strength and fine touch position, vibration on the side of the injury. So that's ipsilateral. Loss of pain and temperature sensation on the opposite side, contralateral. Bladder function is maybe spared and got cut off on the bottom there, but it's in your PowerPoint notes. I just refreshed when they decussate. We already went over that. Early treatment, high dose steroids again, okay? Evidence is limited, but blast them with steroids, trying to get that spinal cord inflammation reduced as fast as possible. Obviously, you got to get your neuro consults, got to realign that spinal cord via traction or other procedures. Prognosis is poor for these Brown-Séquard patients, largely dependent on the etiology of the syndrome. How did it occur? What happened with the injury? So when you go through these ortho and these neuro cases, the mechanism of injury is very important. What happened right before they got injured? Okay, what were they doing? When do they hear a popping sound and so forth? You have to figure out what the mechanism of injury is. Moving on to epidural spinal cord compression. This is a tumor that's pressing on the dural sac. Again, often metastatic in this case when you get to these spinal tumors. Presents with pain, especially at night. So when they lie down at night on their back, that tumor will start to compress the spinal cord and causing the pain to get worse. They may get some weakness, some radicular sensory effects. Lower motor neuron deficits will result in weakness. If there's compression of the posterior nerve roots, we know all sensory is posterior nerve roots. So if you get compression of the posterior nerves, they're going to have sensory issues because that's what's being compressed. It may have some paraplegia and may result in incontinence as well. Can cause permanent neural impairment even if treatment is delayed for a few hours. That's why pain worse at night is a must not miss symptom. You have to ask, is the pain worse at night when you lie down on your back? Again, pain is the most common presenting feature, and they may be incapacitating at night when they're recumbent. So obviously, can you get an MRI in this patient? Probably not. I'm not going to be able to lay down with you and get it all done. Insidious onset, because again, it's a tumor. They take a long time to grow. Rapid course with metastatic tumors, and obviously any history of cancer in the past. So ask your questions. Any history of cancer? Where was it? How were you treated? So on and so forth. So here's an MRI, and you can see right here, it's pushing on that spinal cord. So you have some compression right there, and you have another compression down here, and you can actually see that pushing on that spinal cord with these tumors. So urgent CT or MRI with any patient with any type of neurological complaints. Emergent referral to neuro and oncology, because obviously this is a cancer as well. They need to be on board, figure out what they want to do to try and reduce the size of this tumor. May need immediate radiation to try and shrink it because you don't want to have any permanent neurological damage from this tumor. Again, prompt treatment to improve outcome. So faster the treatment, the better. Intervertebral disc prolapse. These are your herniated discs. Okay, and you can see here, this is the herniation, and it's pinching that part of the spinal cord. That's why herniated discs, that's only pinching one side. So you're going to have effects just on that one side. The other one's going to be okay. That's why people with herniated discs may complain about pain in one leg versus the other, because you're only pinching one side of the spinal cord. The other one's still okay. So this nucleus propulsus herniates and presses on the nerve roots. May come on with heavy lifting, it may not. So people say, oh, I'm lifting really heavy and I hear a pop. That could be a herniated disc. Again, radicular symptoms. It's going to follow that nerve root distribution and go along that dermatome. And that's where they're going to have their pain. Cauda equina syndrome is a herniated disc. The problem is it's central. It's not tilted to the right or the left. So it's central, and it compresses both sides of the spinal cord. Because it compresses both sides, they get bilateral symptoms. Can also be caused by tumor infection and so forth. Variable motor and sensory loss in the lower extremities, but this is the important one. It's called saddle anesthesia. If you ever rode horses and you get off the horse, your butt hurts for a little bit, gets a little numb for a little bit. That's what it's going to feel like. That's why I call it saddle anesthesia. In the groin area on both sides, it's going to feel numb, it's going to hurt. They may also have some bladder or bowel incontinence. Okay, urgent MRI, urgent consultation with neurosurgeon for these patients. Anyone coming in with saddle anesthesia and you think they have a cauda equini, get imaging and get neurosurgeon on the case immediately. So you can see here, right in the center, and we're pushing on the central part of that spinal cord, both sides are now going to be affected. And that's what cauda equini is. So what do we do about disc prolapses? Plain x-rays to start. Here's where that whole CT MRI thing, again, if they're just coming with lower back pain, maybe going down their leg, but there's no other issues, they have no bladder or bowel incontinence, it's just one-sided, they'll get one eventually. But again, if they have a neuro deficit, persistent pain despite treatment, get an MRI CT, see what's going on there. If they have significant radicular symptoms or signs, like 3 out of 5 muscle strength, get neuro involved as well. Have them evaluate the patient. You kind of go bed rest versus activity versus physical therapy. Where is your patient at? How much function do they have to begin with? Where do they want to return back to? That kind of determines how aggressive you are. Pain control is the biggest thing. You can give us just simple analgesics, just Tylenol, Motrin. Then if that's not working, then you can go on to your muscle relaxants, Scalaxin, and so forth. Finally, epidural steroid injection. You have to play the insurance game, and you gotta go from least invasive to most invasive. So you have to start off with pain meds, oral. If those don't work, then you can go to injections. If that doesn't work, then you can be considered for surgery. But you gotta follow the steps first. So that's why it's an order of least invasive to most invasive. Here is amyotrophic lateral sclerosis, also known as Lou Gehrig's disease. It's a progressive disorder, so once it starts, it doesn't stop. It gets progressively worse and worse and worse. We get degeneration of the cortical spinal pathways down to the anterior horn cells. So is this an upper motor neuron problem or a lower motor neuron? The motor nerve is degenerating from the muscle. Lower, because it's going from the muscle itself. But in this one, they actually get a mixed upper and lower are found in the limbs. Easy fatigability. They do have normal sensation. This is pure motor. And it usually presents between ages 30 and 60. So they also may have this cortical bulbar involvement as well. When you hear cortical bulbar, think of the mouth. Okay, if you watch the first Joker movie with Joaquin Phoenix, he actually explains he has cortical bulbar. I forgot what the rest of the words are. That's why he starts laughing at random times. It's a real problem. But it has to do with your cortical bulbar. It's around your mouth. Those are the muscles that are involved with the mouth. So because of the mouth is involved, you can have upper and lower motor neuron problems, difficulty swallowing, chewing, difficulty coughing. So they get aspiration pneumonia. Eventually the breathing becomes a problem. They can't support their own breathing because the muscles of respiration don't work anymore because they've been degenerated with the nerves get pulled off. There's no nervous impulse. Muscles won't do anything. Difficulty speaking. Tongue fasciculations is a classic finding with ALS. Intellect is normal. This is just motor. And what's a case of a person with very high intellect who had ALS? Stephen Hawking. Okay, he had ALS. Eventually he was stuck in the wheelchair. He couldn't support his own breathing. But the brain still worked and he was able to communicate and obviously write papers and all that stuff. So what is going on with ALS? So it's a mixed upper and lower problem. So we know we're obliterating the descending tract. So this is where the muscle comes, the motor neuron comes here. And remember, it crosses over And this is where the synapse occurs. And then that goes out to where it's got to go. But with ALS, we blow that up and we blow that up. So the upper motor neuron is damaged. The lower motor neuron is damaged as well. So you're destroying the anterior gray horn and the descending tract. The descending tract has the upper motor neuron. The anterior gray horn is where the synapse occurs, where the lower motor neuron is. That gets destroyed. So the lower motor neuron stops functioning and the upper. And that's why ALS is a mixed upper and lower problem. Both nerve sets are damaged and destroyed. Again, no sensory, cognitive, or oculomotor deficit. They're okay. Why oculomotor? Is that a peripheral nerve? Central. 1 and 2 are central. Everything else comes off the periphery. But oculomotor stuff is okay. Muscle biopsy may reveal, again, denervation atrophy. The nerve pulls off. You may want to get a nerve biopsy to see what's going on. You can do your EMG to see how the muscle is doing. Again, fasciculations in both upper and lower limbs. Normal conduction velocity because the nerve itself is okay. The myelin is still on there. There's no issue with demyelination. It's just the motor nerve pulls off the muscle and it doesn't attach anymore, therefore no stimulus. Normal sensory. Treatment, riluzole, inhibits presynaptic glutamate release, slows progression of the disease, but prolongs survival by several months. Again, there is no cure for ALS. And again, management of symptoms. That's the biggest thing you do a lot of times with neuro. Management of symptoms. Again, here's your spasticity, baclofen. Mobility. These are the things you have to start thinking about. When you guys get into geriatrics, you can go through a lot more of these things with Professor or Dr. Stewart now. When it comes to like, how does your patient go home? What do they need at home? What kind of medical equipment do they need? Dysphagia, because obviously the cortical bulbar muscles are affected. They can't chew. They have problems swallowing. What are you at risk of with all those problems? Choking and aspiration pneumonia. Those foodstuffs get into your lungs, cause a big infection. So eventual feeding tube via peg tube. Excess salivation. You can give amitriptyline, which is an anticholinergic. Remember, one of the signs of anticholinergic disease is dry mouth. So you give it to them because you want that to stop. You want the excess salivation to stop. Dysarthria, just give them some communication devices. They may eventually hit respiratory failure and get some positive pressure ventilation, so those CPAPs and stuff like that. And again, progressive disease, fatal within 3 years. Stephen Hawking obviously lived a lot longer than that, but on average within 3 years. Okay, let's take a break. Come back at 1:30. Got 7 minutes. Okay, let's get started. So the first section we did, we're just going over the spinal cord issues itself. Now let's move on to our peripheral nerves and kind of learn about some peripheral nerve issues with the nerves itself. So these are the isolated peripheral neuropathies. Okay, so this is just one nerve has an issue. If the facial nerve has a paralysis, it's called Bell's palsy. And we'll go over Bell's palsy in the next unit, but that is the facial nerve paresthesia, neuropathy, results in Bell's palsy. Radial nerve is Saturday night palsy, and I'll show you a picture of that in a second. If your median nerve gets compressed, that's your carpal tunnel syndrome. Your ulnar nerve is your funny bone, so if your elbow weird, and your forearm and hands get a little tingly and everything, that is the ulnar nerve. Lateral femoral cutaneous nerve is neuralgia paresthetica. Your deep perineal nerve gets compressed in compartment syndrome. That's a surgical emergency. You got to decompress that. Posterior tibial nerve neuropathy results in tarsal tunnel syndrome. So this is Saturday night palsy. Gabby likes to call it Saturday morning palsy. Carpal tunnel. Again, compression of that median nerve, more females than males, risk factors, obesity, coexisting conditions, aromatase inhibitor use, and obviously the big one is this repetitive hand use and everything. So obviously ask what they do for work. So with carpal tunnel, they start getting different sensory issues, so you gotta really be careful with your assessment of the dermatomes in the hand. Pain or paresthesias of the median nerve distribution, first 3 digits and radial half of the fourth. That's the distribution for that nerve. Worse at night, provoked by activities that have flexion or extension of the wrists. And again, alternating periods of remission and exacerbation. It'll be fine for a while, then it flares up again and so forth. Some tests that you can do to make that pain producible, to see if they actually have carpal tunnel syndrome. The first one's called the Phelan maneuver. Flex the palms of the wrist with elbows in full extension. So positive test is pain or paresthesias in that median nerve distribution. The next one is called the Tinel test. Firm percussion over the course of that median nerve, and a positive test will be pain is elicited. Okay? So testing for carpal tunnel, EMG, nerve conduction study, you can get those going, see if there's any diminished nerve impulse going down to the wrist, how the muscle is doing in the hands. Imaging is only useful if there's any structural abnormalities that need to be ruled out. Treatment, surgical decompression of that nerve is the most common one. If failed, you can try splinting, some glucocorticoid injections. Again, steroids, they're going to reduce the swelling, some oral therapy as well for carpal tunnel. A lot of the problems also with carpal tunnel also happen in the neck. Okay, you guys are all at your computers a lot now, so your head tilts forward a little bit while you're looking at your computer. And just that head tilt sometimes can cause neck pain, and it can, again, you have your brachial plexus, that can compression up here and goes all the way down, causing wrist issues. Multifocal peripheral neuropathy. So if you have a patient that has numbness and tingling in multiple parts of the body, it's multifocal. Whereas the ones we all described are just one nerve causing one part of problems in certain parts of the body, wherever that nerve goes. If you have peripheral neuropathies that are multifocal, that's usually going to be some systemic or metabolic disorder that's causing that issue to happen. Okay? Vitamin B12 deficiency is a big one. Distal symmetric sensory motor polyneuropathy from vitamin B12 deficiency. Alcoholism, again, distal symmetric sensory motor polyneuropathy. Leprosy, again, sensory problem, and your diabetes. They get stocking glove neuropathy, feet and hands. Multifocal because multiple nerves are now involved. Multiple sclerosis, moving on to this one now. Inflammatory process thought to be from an immunologic disorder. So there's usually some sort of autoimmune issue causing multiple sclerosis to occur. Usually going to be an insult somehow. They were sick, had a viral infection, something that sets off the autoimmune process. They get multifocal demyelination of the white matter of the brain and spinal cord. Why the white matter? That's the axons. Fat is white. Okay. Patients will have relapsing remitting pattern with chronic progressive course. Every time an MS patient has a relapse in symptoms, that usually means a new plaque has formed. There's a new issue somewhere that caused more issues to occur. So, demyelination of the white matter. Wherever you see these red dots, these red markers, that's a plaque, and that means that that part of that spinal cord is damaged. Mostly going to happen in the cervical cord. Asymmetric lesions. These are distributed in space and time, just like Paul Atreides and Dune. What does that mean? This can occur at any level of the spinal cord. You may have an issue in T10, and then a few months later, a new plaque starts at C5. And then a few months later, a new plaque starts at C2. So it depends on where you are at space of the spinal cord or time, when does it occur. They get intention tremors, scanning speech, and we'll go through the symptoms in a second here. Strong genetic component with MS, 10,000 new cases annually, primarily disease of Caucasians, Northern European descent, more females than males, and usually mid-30s is when multiple sclerosis will start to present in a serious format. Signs and symptoms of multiple sclerosis, and I have a picture for you guys to remember all this stuff. May have ataxia, positive Babinski sign. This is usually the big one. Blurred, double vision, loss of vision in a single eye. Okay, so watch for eye complaints, vision problems. Clonus, what's that? Repetitive movements. Usually one is normal, more than one at a time is not. Clumsiness, because the muscle functions aren't working anywhere. They'll trip, they'll fall easy, they'll drop things. Emotional decline, fatigue, hand paralysis, loss of position and vibratory sense, because look, it can occur back there as well. And that's where your dorsal white columns are, and that's where your pain, proprioception, position sense are. That's why they have problems walking with position sense, because depending on where these lesions occur, they're not going to have great success in movement of those functions. So diagnosis is made from clinical and your lab features. MRI is more sensitive than CT, and what you're looking for are these plaques, these Dawson's fingers. I'll show you some pictures of that in a second. CT scan can also show plaques. You can also do what's called an evoked potential test for multiple sclerosis. This want to see how fast your muscles respond to a stimulus. And what kind of disease is multiple sclerosis? Demyelinating disease. So is that conduction going to be able to travel as fast as it should? No, and that's what you're going to see. You're going to see a reduction in conductive velocity with these potentials. You see it's abnormal in 75 to 90% of definitive MS cases are going to have some deficiency in these potentials. You can also do a somatosensory evoked potential, an auditory brainstem evoked potential. There's a bunch of different ones, but remember, we're looking at nerve function. Demyelination occurs, the velocity through these nerves is not going to be as fast and as strong as it should be, so anything downstream of that will become weak. So these are those Dawson's fingers, all these little things right here. Okay, that's Dawson's fingers. Obviously, you can only see it on imaging. CSF abnormalities. So all this demyelination gets absorbed, all this myelin that gets eroded and taken out gets absorbed by the CSF. So we have increased immunoglobulin levels in these patients, increased lymphocytes. This is the big one right here, these oligoclonal bands. That's pathognomonic for multiple sclerosis. So if you ever see anything on a question talking about oligoclonal bands, it's referring to MS. Myelin basic protein may be elevated. Makes sense because demyelination, or that myelin protein, goes into the CSF, so you may have excess myelin. Glucose is usually normal because there's no infection. There's no bacteria to eat it up. So this is not an infectious process, this is an inflammatory process. There's this thing called McDonald's criteria. You don't have to know what it is. You know why? Because you have a phone. And your phone's got Medscape in it. And if you use Medscape, it's got all the formulas there. I want you to know that McDonald's criteria is used for MS. So if you have a patient you suspect MS, oh, McDonald's criteria, let me pull out my phone and just enter the numbers and it'll give you the report. Okay. Basically what it does, looks at the number of attacks that you've had and the amount of lesions on the brain through MRI and any CSF findings. You put all those numbers into the formula and it gives you a result. Again, there must be no better explanation than MS for these patients. Relapsing, remitting, again, anytime there's a new sign, symptom pop up, that means there's a new plaque that formed as well. Signs and symptoms develop in acute relapses followed by recovery. Usually that goes on for the first 5 to 10 years. 60% will develop secondary progressive MS, 90% in 25 years. What is secondary progressive MS? Gradually worsening following the initial. So over time, these relapses and remissions get worse in intensity and they become more frequent. So they're going to start happening more regularly. That's why that McDonald's criteria is how many number of attacks have you had in the past year? How many flare-ups? There was 2 the previous year, now it's up to 4. The MS is getting worse because you're getting more attacks now, more flare-ups. So here's your little summary slide of the different signs and symptoms of multiple sclerosis, kind of puts it all together for you. Treatment, again, you're not going to cure MS, but let's relieve their symptoms. Okay, corticosteroids, whenever they have an attack, you give them corticosteroids. Okay, we want to reduce the inflammation. Another thing you can do too for people who can't do steroids, plasma exchange called plasmapheresis. Short-term use for attacks helps get rid of the immunoglobulins that promote all the inflammation. Some disease-modifying drugs for relapsing MS, your interferons are here. You don't need to know all these things. You hear interferon, think MS. Again, the goal, reduce the frequency and severity of the clinical attacks. We want to prolong their life. May delay eventual disability so they can live with MS. They'll have less frequent flare-ups, but they can still happen. IVIG can also help, and obviously, and regular exercise helps with MS patients. Improves conditioning in advanced disease, and it helps. Treatment, again, spasticity, baclofen. Okay, the spasms in the muscles, give baclofen. Other drugs to reduce neuropathic pain. So in MS, the problem is the nerves. Bless you. Okay, so the nerves are causing the pain. It's not muscle, it's not bone pain, it's the nerve transmission that's causing the pain. So these are the drugs that we give to help blunt the nervous response. So reducing the pain that you get. Again, this is neuropathic pain. Again, if someone's coming in with a sprained ankle, these medicines aren't going to do anything for them because the problem is not the nerve. The problem is muscle, swelling in the area. So one of the big ones, gabapentin, Neurontin, that's usually the first line we give for neuropathic pain. Drugs to reduce chronic fatigue, amantadine or Simitrel, modafinil, Provigil, helps with chronic fatigue that these MS patients will have. And obviously be careful with exposure to heat. It can make their flare-ups worse. So they have to be they can't go into saunas, be very careful exercising in the heat because that can make their MS flare up. Prognosis. Partial recovery from all those episodes can be anticipated. You don't know when the next one's going to happen. So whenever you get a new demyelination occurring, that's where you start getting your signs and symptoms. Best prognosis, female gender, onset before age 40. And they get visual or somatosensory deficits, touch, tactile perception, rather than pyramidal or cerebellar. What is pyramidal and cerebellar referring to? Movement, motor function. If they have just sensory issues, better prognosis. If they start getting muscle involvement, that's a little worse. Around 50% are only mild or moderately disabled after 10 years of onset of symptoms. The next one is complex regional pain syndrome, CRPS. This is a disorder of the body region, usually the distal limbs. So it's a limb problem, not a specific muscle or whatever, the whole limb. Pain is the biggest thing. It's called pain out of proportion. They look okay. Imaging doesn't show anything. Labs don't show much, but they're in severe pain in their leg. out of proportion to your physical exam. They should not be in this much pain based off of your physical exam, but they are. That's usually one of the clinical signs to think of when it comes to CRPS. Pain out of proportion. Swelling, limited range of motion because of pain. Skin changes, patchy bone mineralization, usually follows a fracture, soft tissue injury, or surgery. There are two subtypes of CRPS. Type 1, which is the most common, without peripheral nerve involvement, so the nerve is okay. That's 90% of them. In type 2, they have peripheral nerve injury as well, which that helps, but adds to the pain that they're having. Management, everything with neuro is earlier the better. Obviously, they need PT/OT, pain management, NSAIDs, you give ibuprofen or naproxen, that will help. Anticonvulsants, gabapentin, here's your neuropathic pain inhibitors. Also, TCAs can also help with nerve pain as well. So the ones that have the peripheral nerve injury, these will do very well because these help block neuropathic pain. And their nerves are what's causing the problem. Prognosis, uncertain, ongoing diagnosis, about 64% of cases, usually last about 7 months for the CRPS to occur, the pain. So this is start now, it's mnemonic. So start is the signs of CRPS. So here's your agony, out of proportion pain, not improving as expected. So that's one of your big ones right there. And then now is how do you treat it? Nerve meds, your gabapentin, Lyrica, opioids, be careful with those. They get dependency on them. And workouts. Keep that limb moving. Now, opioid meds, if you're telling someone to work out, but they're having pain, when should they take their pain meds? After or before they work out? Before they work out. So this way the med is working while they're working out and their pain is reduced. And if their pain is reduced, they can work out longer. Because if pain is not controlled, the minute they start doing something, it's going to be painful. They're going to stop immediately. But if you can blunt the pain, then they can work out a little bit more. Polio is the next one. Okay, it should have been gone, but it's coming back a little bit. You can read all that on your own, it doesn't matter. Usually there's a viral infection and it causes destruction of the anterior horn cells. What goes on in the anterior horn cells? Synapse between what? Upper and lower motor neurons. So we're destroying the area where the synapse occurs. Usual route infection for polio is fecal oral. Have an incubation of about 1 to 3 weeks. Prodrome, fever, myalgias, and some URI or GI symptoms. That sounds very vague. But what kind of question would you want to ask this patient? What about just talking about history and physical history? Were you vaccinated? Did you get vaccinated for polio? Were you around anyone who hasn't been vaccinated for polio? Weakness or paralysis, again, lower motor neurons are destroyed now. They're not going to work. So you get paralysis. If the respiratory muscles are affected, you're not going to be able to breathe on your own. And that's why they go into those iron lungs. Diagnosed via viral isolation from stool or nasopharyngeal secretions, and there's no specific treatment. And these are the iron lungs. And I think there was like one person still left in an iron lung. I think he just passed recently. But those are the iron lungs, and they put them in there and it changes the pressure. It allows their lungs to expand and deflate so they can breathe. So, anterior gray horns are destroyed. They get lower motor neuron symptoms with polio. Because you're destroying the anterior gray horns, there's no more synapse. Lower motor neurons don't do anything. Herpes zoster, reactivation of the varicella virus, severe, and the pain may precede the appearance of the rash. Skin lesions are similar to chickenpox, so maculopapules and vesicles and pustules later on. Lesions follow the nerve root distribution. Remember, herpes likes to live in the cell bodies. And when it gets annoyed, it comes out. And it follows the axon, and whatever dermatome that's in, that's where you're going to have the eruption. It's going to follow the nerve, all the nerve endings, and it comes out. Thoracic and lumbar roots are the most common, but the trigeminal can be possible, and it's not good if you have trigeminal distribution for herpes zoster. Yes?
I'm sorry, I had a later
That's okay.
question. So it's not like MS where it just continues to cause damage, right? Like when you get polio, it damages one spot, so like your arm.
Well, it's going to get progressively worse and worse and worse.
Progressive once you get it. Okay.
If you have a lesion on the tip of the nose, it's called Hutchinson sign, and it indicates ophthalmic division disease. If that happens, you have to go emergently to the ophthalmologist, okay? Not the optometrist in the mall. You have to go to the ophthalmologist, okay? There's a big difference. So this is what herpes zoster looks like. Again, following the dermatome pattern. Okay, herpes zoster. Treatment, antivirals, acyclovir, valcyclovir. Steroids may or may not work, but use it for severe cases. Pain relief is going to be the biggest thing for these patients. It is very painful when they get shingles, essentially is what it is. Postherpetic neuralgia treatment. This is neuralgia. It's nerve pain. So you have to give gabapentin or amitriptyline. Those are your neuropathic pain drugs. They're having nerve pain. So think about that when it comes to like neuro and ortho, talking about different types of pain. If it's muscular, degenerative joint disease, skeletal muscle pain, that's inflammatory. You can give Tylenol, Motrin, and those type of drugs. They're not going to do anything for a nerve type of pain. Here's Guillain-Barré, also known as acute inflammatory polyradiculoneuropathy. Autoimmune disorder, usually there's some sort of insult that happened before they got these symptoms. Destruction of the myelin or axon. Peripheral nerve. So MS is central nerve demyelination. Guillain-Barré is peripheral nerve demyelination. Usually an ascending paralysis. Starts in the feet, goes up to the ankles, the lower legs, and so on and so forth. It works its way up. Again, following an infection, immunization, surgical procedure, Campylobacter jejuni can also cause Guillain-Barré. 30% of patients will have some sort of respiratory paralysis. So you have to watch for breathing problems with these patients. It's a neurological emergency. Watch for autonomic instability. What are some signs of autonomic instability? Postural hypotension. Okay, they can't regulate autonomic function. They may require mechanical ventilation. Usually the maximum deficit will last 4 weeks. Recovery is on its own, it's self-limiting. You just gotta wait. You gotta wait for that myelin to regrow and deposit itself and that nerve to become intact again. So it could take weeks to months to recover from Guillain-Barré. Some patients need to learn how to walk again because of that ascending paralysis knocked out their feet and caused some muscle weakness. Remember, this takes a couple of months to recover. They have to learn how to walk again. Incidence, prevalence, 1 to 8 on 100,000, non-seasonal, non-epidemic. More males than females can get it. And ask about any prior events that happened prior to them getting these types of symptoms. Okay, where they have a viral URI, they have Campylobacter jejuni infection causing diarrhea, immunizations. Okay, you hear it a lot with the flu vaccine. And so ask these questions. What was going on before all this happened? Signs and symptoms, again, paresthesias of the hands and feet, that's usually the earliest one. Acute, symmetric, ascending weakness of the limbs. Both sides are going to be affected. Gait disorder is common, again, the lower extremity muscle weakness. They're going to have troubles walking. Pain is common. Be careful for respiratory muscle paralysis. There can be some cranial nerve involvement in 50% of the patients. Some differentials for Guillain-Barré could be a stroke, encephalitis, Lyme disease can also present like Guillain-Barré, and your myasthenia gravis. Diagnostics, get a lumbar puncture, elevation in CSF protein without elevation in white blood cells. Okay, increased protein because this is myelin, it's protein, it's all being degraded, it's getting dumped into the CSF and you can pick it up later. You don't see increased white blood cells, why? There's no infection, it's all inflammatory. And you can do some electrophysiology studies and obviously your nerve conduction is going to slow down because you're demyelinating the peripheral nerves. Treatment, symptomatic, so whatever symptoms they're having, supportive treatment, hospitalization, watch out for cardiopulmonary support, especially if the ascending paralysis got so high that now it's affecting your muscles of respiration. You can do plasmapheresis, IVIG, you restore your healthy antibodies, and obviously analgesics as well. Prognosis, it's a self-limiting disorder. It's going to stop on its own. Nothing you're going to do is going to make it go faster. Whenever it's ready, it's ready. 75% make a full recovery within a few months to a year. Some may need rehab. Like I mentioned before, they'll lose their ability to walk. So they have to relearn how to walk again. 5 to 10% will have a lingering severe disability. 5 to 10% will have one or more relapses. Death rate 2 to 3% for Guillain-Barré. So here's a summary slide for Guillain-Barré. Diabetic peripheral neuropathy, most common cause of a peripheral neuropathy is due to diabetes. Okay, insidiously progressive, length is dependent, can affect any peripheral nerve, including your cranial nerves. Occurs secondary to vascular insufficiency, nerve infarct, associated with hyperglycemia. So any patient that's coming in who's a diabetic and they got neuropathy, what do you think the number one treatment is? Glucose control. It's always get that sugar under control. No matter how much medicine you throw at this patient, if their sugars are still high, it's not going to get fixed. They have to get their sugars under control. Most common in toes and distal feet, it's like a tingling or a burning. Temperature sensations are off. Reduced Achilles tendon, vibratory sense in toes. Hand numbness will develop later, so it's called a stocking glove distribution. Hands and feet is where it starts. Diagnosis, you get some serial nerve conduction studies and see, is that nerve conduction getting worse over time? That means that nerve is worsening. Rule out other causes of polyneuropathy. So uremia, here's your ETOH, B12, hypothyroidism. Make sure you rule out other causes for that numbness and tingling before you just say, oh yeah, it's just diabetes, and move on. Treatment, here it is, tight control of glucose. Your TCAs for that nerve pain. Remember, this is nerve pain, so you have to give nerve type medicine. Anticonvulsants also helps with nerve pain, that's why we put it there. And aggressive management for pain, lidocaine patch, or you can give tramadol as well to help with the pain. Autonomic dysfunction, again, these are all things that go along with uncontrolled blood sugar. Okay, for treatment, again, orthostatic hypotension, fludrocortisone is a volume expander. What type of hormone does this work like? It's a steroid, so where do steroids come from? Adrenal cortex. Which one deals with volume? Aldosterone. Okay, aldosterone. Gastroparesis, what's that? Slowing of the stomach, it stops moving. Again, autonomic dysfunction. You give Reglan, that's what metoclopramide is. Diarrhea, they may have that as well. You give loperamide. Urinary incontinence, erectile dysfunction, cardiovascular risk factors. Watch out for all those things too. When you're treating your patients, also don't, yes, they're coming with a diabetic peripheral neuropathy, but make sure that they're well controlled in their diabetes, and if they're smoking, make sure you mention that patient stop smoking, and so forth. Preventive measures, again, proper foot care, checking their feet daily, annual foot exam with monofilament testing. What's monofilament testing? It's like one little filament of steel, and what you're doing is you put it on the skin and you push, and what happens, that little filament starts to bend, and you want to see how much pressure you have to give before your patient feels that pinprick. And the more bend that filament has, the more pressure you're exerting, which means they're not picking up minute changes in pressure. So that's disorders of the peripheral nerves. Now let's go through the neuromuscular junction and muscle, and then we're done. Tetanus, Clostridium tetani. Okay, toxin exposure from contaminated wounds. Toxin goes to the motor nerves in the spinal cord, and it gets there because of the bloodstream. Toxin is going to bind irreversibly to receptors in the brain and spinal cord, and it blocks the release of GABA. So that's why you have tetany. You can't relax because you're blocked the GABA, which is our inhibitory neurotransmitter, so nothing can shut it off. They get unchecked excitatory impulses, increased muscle tone, spasms, and rigidity. So this is what tetanus looks like. You treat with tetanus immune globulin. Obviously, you guys get boosters for tetanus every 10 years, but if you do have a tetanus infection, we just give you the proteins and the immunoglobulins to take care of it. Watch for respiratory and cardiovascular support. Fatality rate is up to 70% with tetanus. Botulism. Okay, what does botulism do? Binds to the presynaptic side of the cholinergic synapses, and it disrupts acetylcholine release. So if there's no acetylcholine release, there's no muscle contractions, and therefore no wrinkles if you can't move your forehead muscles. You don't get wrinkles. That's what Botox does. Can cause motor weakness or paralysis. May include muscles of respiration. So obviously if your muscles don't work and you can't breathe, then you're going to be in a lot of trouble. Be careful with home canned foods that can be contaminated with the toxin. Rarely from infected wounds, and infants are at risk, which is why you can't give infants anything out of a can until they're a lot older. So clinical findings, they're going to get weak 12 to 72 hours after ingestion of the toxin. It's a symmetric descending paralysis. So it starts at the top and works its way down. Which one is an ascending paralysis? Guillain-Barré. But botulism is a descending paralysis. Symptoms can progress for several days after onset. Vision problems, facial mouth issues, facial weakness, dry mouth, dysphagia. Here's your paralytic ileus. Just stops things from working. No sensory deficits because we're not dealing with any sensory problems. We're dealing with acetylcholine receptors at the neuromuscular junction. Acetylcholine can't get released, therefore the muscle will not do anything, but it's only muscle, it's not sensory. Normal DTRs unless the involved muscles are affected. Treat botulism with an antitoxin and supportive care, and watch out for respirations. Myasthenia gravis, autoimmune disorder, pure motor syndrome. Okay, myasthenia gravis is just motor. What myasthenia gravis does, it blocks acetylcholine at the postsynaptic receptors. So acetylcholine can't bind to it because myasthenia gravis, the autoimmune, blocks those receptors, and therefore nothing gets transmitted. Most common, females over males, can occur at any age, but usually 20 to 40. Males in the third decade, females in the third decade. Males will peak in that fifth or sixth decade. So this slide you've had in physio before. I think I can put it in pathophys. But remember, here's your aminoglycoside antibiotics. They also have an effect. Here's your botulism. It blocks the release of acetylcholine from the presynaptic. Here's your myasthenia gravis, and they obliterate the acetylcholine receptors, so they can't bind to anything, causing transmission of the signal from the nerve to the muscle. That's where myasthenia gravis comes in. So, characteristic muscular weakness. Worse in the evening. They have some extraocular problems. They're going to have some ptosis on the eyelids. Okay, lid lag. Some pharyngeal and facial issues, cervical, proximal limbs, shoulders and hips. They're going to have problems with shoulders and hips. Respiratory may have some issues there if there are the muscles affected. Onset is mild, intermittent over many years. A myasthenia crisis can last hours or days. They're in severe pain, problems doing things because of the crisis that's going. So signs and symptoms, biggest ones are eye problems. Ptosis, diplopia, blurry vision, double vision. And then it gets, goes down from there. But ptosis, diplopia, those eye issues are usually the biggest signs they're going to have. Proximal limb weakness we talked about. Respiratory weakness can also happen. Muscle fatigability post-exercise. Muscles they get very, very weak very fast. There's another one called Lambert-Eaton or myasthenic syndrome, Lambert-Eaton. These are defective acetylcholine release, so it can't be released from the presynaptic membrane. Things that can cause this, antibodies against the calcium channels, small cell lung cancer, Lambert sign is important to know. Increased power with muscle contraction, and improvement on repeated hand grip strength. So as you keep doing your hand grip, if you keep doing it, they'll have improvement, because what happens is every time they go to squeeze, more acetylcholine gets dumped. So they'll have more acetylcholine floating into that synaptic cleft. Hopefully all those extra acetylcholine molecules can have a greater effect on the postsynaptic side, producing better contraction with repeated movements. And these are some, obviously, your differentials for myasthenia gravis. Guillain-Barré is there, multiple sclerosis, chronic fatigue, but make sure you have those signs and symptoms to differentiate them. So, diagnosis, it's called a tensilon test. You give them idrophonium. It's basically a acetylcholine esterase inhibitor, so the acetylcholine sticks around longer. We need that acetylcholine to sit around because we need more of it to have an effect. 4 milligram IV will improve grip strength within 30 seconds. You can get your electrophysiology studies, see how the EMGs are doing, precipitation assay. Acetylcholine receptor antigen is what you're looking for. Acetylcholine receptor antigen. It's going to sit in that receptor, block it so that acetylcholine can't have any effect. Treatment, again, anticholinesterase therapy. Okay, the big one is this neostigmine. Okay, helps to strengthen that neuromuscular transmission. Immunosuppressant therapy. Prednisone is a big one. These other ones are very strong drugs that deal with immunosuppressant therapy. So anyone going in for organ transplants will go on these stronger ones to knock out their immune system, so when the new organ comes in, their body doesn't attack it. Plasma exchange, your IVIGs. Surgical treatment, thymectomy. This is where the thymus gland comes back into play. People with myasthenia gravis, get rid of the thymus gland. It doesn't really do much in adulthood, but because we know 10% have thymomas with myasthenia gravis, just take it out. And usually we'll be done between 3 and 6 weeks of prednisone therapy. So you want to shrink it and then get rid of it. We have like 5 slides left. Okay. Polymyositis or dermatomyositis. Autoimmune disorder, inflammatory infiltration of muscle. So we're now putting stuff into the muscle fibers. Now we're in the muscle now. Okay. We went from neuromuscular junction. Now we're dealing with the actual muscle itself. So we get destruction of your muscle fibers, muscle pain, weakness, and wasting. mainly in the proximal muscles. And you'll get a lot more with this with Dr. Ovalle with rheumatology this spring as well. But here are some of the major signs and symptoms for polymyositis and dermatomyositis, the heliotrope rash. And these are called Gottsched's papules. And those are usually with dermatomyositis. Muscular dystrophy, inherited, so it's genetic, you're born with this. Progressive muscle weakness and wasting. It's broken down by how they got it, when the age of onset, when did it happen, clinical features. No specific treatment. Avoid prolonged bed rest. Why? What do you want to avoid? Clotting. You want to avoid pressure ulcers, so keep them moving. Encourage activity. Keep them moving. PTOT. And you can give eteplirsen, which is an antisense oligonucleotide, and it slows the rate of disease progression. Cerebral palsy, okay? Heterogeneous conditions involving permanent, non-progressive central motor dysfunction. Usually happens during development. Traumatic childbirth can cause cerebral palsy, okay? Mostly prenatal, before they're even born. Management, multidisciplinary team. So again, help with their social and emotional development, communication, education, nutrition, and so on and so forth. All the other, like, you're not going to treat the cerebral palsy, it's not going to go away, but there's a lot of other conditions you can help with that patient for quality of life. They get spasticity, hyperreflexia, can interfere with performance. So you can give them Botox in this case. You give them the botulism to stop the muscle from working, and that helps reduce their spasticity and the hyperreflexia by giving them Botox, and it knocks out the muscle. Obviously, these are the mainstays of treatment, PT, OT for these patients. Problems with feeding can be common in children with cerebral palsy, and obviously can interfere with nutrition if they're not eating right, or if they can't swallow right, they're at risk of aspiration pneumonia. Prognosis depends on severity and their type of cerebral palsy. And we're done with this one. So tomorrow we'll do a review for the exam on Friday. Okay, I'll see you all tomorrow.